Calcific tendinopathy of the shoulder is a common and often painful condition where calcium crystals deposit in the tendons of the rotator cuff. Most frequently, it affects the supraspinatus tendon, but other tendons like the infraspinatus, subscapularis, and teres minor can also be involved. This buildup of calcium can lead to significant discomfort, especially during shoulder movements, and may limit a person's range of motion. While the exact cause isn't fully understood, it's clear that this condition can impact daily activities and quality of life. In this video, we'll explore what calcific tendinopathy is, how it develops, and why it's important to recognize its symptoms early. Calcific tendinopathy is more common than you might think. It tends to affect women twice as often as men, and most cases occur in adults between the ages of 30 and 60. Interestingly, many people with this condition may not even realize they have it, as some remain asymptomatic. However, for those who do experience symptoms, the pain can be quite severe and disruptive. Certain groups, such as those with diabetes or metabolic disorders, are at higher risk. Understanding who is most likely to develop calcific tendinopathy can help with early detection and management. Several factors can increase the risk of developing calcific tendinopathy. Occupations that require repetitive arm movements, especially internal rotation and slight abduction such as desk work, cashiering, tailoring, or factory line work, are notable contributors. Additionally, frequent overhead activities can also raise the risk. Medical conditions like diabetes, hypertension, ischemic heart disease, hypothyroidism, and certain metabolic disorders are linked to a higher likelihood of developing this condition. Recognizing these risk factors is crucial for prevention and early intervention. Understand calcific tendinopathy. It helps to know a bit about shoulder anatomy. The shoulder is a complex joint made up of bones like the humerus, clavicle, and scapula, as well as several muscles and tendons. The rotator cuff, which includes the supraspinatus, infraspinatus, subscapularis, and teres minor, plays a key role in stabilizing and moving the shoulder. These tendons pass through the subacromial space where friction can occur. The subacromial bursa acts as a cushion, reducing friction during movement. When calcium deposits form, they often do so in these tendons, leading to pain and restricted motion. Development of calcific tendinopathy is complex and not fully understood. Several theories exist, including tissue degeneration from chronic wear and tear, reduced blood flow, ischemia, and reactive calcification. The process often starts with changes in the tendon structure, leading to the formation of fibrocartilage. Over time, calcium crystals deposit within this tissue. Eventually, the body may attempt to resorb these deposits, causing inflammation and pain. This cycle of deposition and resorption can last for months, and the severity of symptoms can vary widely between individuals. People with calcific tendinopathy typically present with shoulder pain that can be either sudden or develop gradually. The pain often worsens with movement and may limit the range of motion. Some individuals experience tenderness over the outer part of the upper arm or the subacromial area. In severe cases, especially during the resorptive phase, there may be swelling, fever, or a general feeling of malaise. Interestingly, some people have no symptoms at all, and the condition is only discovered incidentally during imaging for other reasons. During a physical exam, doctors look for tenderness, swelling, and limited movement in the affected shoulder. Patients often hold their shoulder in a protected position to reduce pain. The examiner will assess both active and passive range of motion, and may perform manual muscle testing to check for weakness. Special tests known as provocative maneuvers like the Hawkins-Neer and Yakum tests can help identify subacromial impingement, which is commonly associated with calcific tendinopathy. Imaging plays a crucial role in diagnosing calcific tendinopathy. X-rays are usually the first step and can reveal the presence, size, and location of calcium deposits. Ultrasound is especially useful for detecting deposits that may not show up on X-rays and can also assess for associated injuries like rotator cuff tears. MRI is generally reserved for complex cases or when other shoulder pathologies are suspected. Each imaging technique provides unique information that helps guide treatment decisions. Several classification systems exist to categorize calcific tendinopathy based on imaging findings. On X-ray, the Gartner and Hare system classifies deposits by their appearance, ranging from dense and well-defined to cloudy and resorptive. The Mole system further divides deposits by density and outline. Ultrasound-based systems like those by Bianchi and Martinelli or Sconfienza classify deposits by their echogenicity and shadow. While these systems help describe the condition, no single system is considered superior for guiding treatment. Not all shoulder pain is due to calcific tendinopathy. Other conditions can present with similar symptoms, including subacromial bursitis, rotator cuff tears, adhesive capsulitis, frozen shoulder, and muscle spasms. In cases with fever or systemic symptoms, infections like septic arthritis or crystal-induced conditions like gout and pseudogout should be considered. Accurate diagnosis is essential to ensure appropriate treatment and avoid unnecessary intervention. Most cases of calcific tendinopathy are managed without surgery. Initial treatment focuses on avoiding aggravating activities, using non-steroidal anti-inflammatory drugs NSAIDs, and starting physical therapy. If symptoms persist, corticosteroid injections may be considered, especially if there is associated bursitis or impingement. Other options include ultrasound-guided percutaneous irrigation barbotage and extracorporeal shock wave therapy. These interventions aim to reduce pain, improve function, and promote resorption of calcium deposits. Physical therapy is a cornerstone of treatment for calcific tendinopathy. Programs typically include stretching and strengthening exercises, with a focus on restoring range of motion and correcting shoulder mechanics. Adjunctive modalities like massage, laser therapy, and cryotherapy may also be used. While most patients improve with therapy, a minority may still require surgical intervention. Consistent participation in physical therapy can significantly enhance recovery and reduce pain. For patients who do not respond to initial therapies, advanced non-operative treatments are available. Ultrasound-guided percutaneous irrigation (USPICT) involves flushing out calcium deposits using needles and saline, sometimes with corticosteroids. Extracorporeal shock wave therapy (ESWT) uses sound waves to break up deposits and stimulate healing. Platelet-rich plasma (PRP) injections and therapeutic ultrasound are also options, though evidence for their effectiveness varies. These treatments are generally safe and can provide significant relief for many patients. Surgery is usually reserved for severe cases or when symptoms persist despite at least 6 months of non-operative management. The most common surgical approach is arthroscopy, where calcium deposits are removed and any associated shoulder issues are addressed. Open surgery is rarely needed. Postoperative rehabilitation is essential to restore function, and most patients can return to light work soon after surgery, with more strenuous activities allowed after several weeks. The outlook for calcific tendinopathy is generally favorable, especially with timely and appropriate treatment. Most patients experience significant improvement, though a small percentage may develop complications like adhesive capsulitis, frozen shoulder, or rotator cuff tears. Rarely, more serious issues such as osteolysis or ossifying tendinopathy can occur. Factors like bilateral involvement, large or medially located deposits, and certain imaging features may increase the risk of persistent symptoms. Regular follow-up and adherence to treatment plans are important for optimal outcomes. Track progress and treatment effectiveness. Clinicians use several outcome measures. These include the Shoulder Pain and Disability Index (SPADI), American Shoulder and Elbow Surgeons (ASES) score, Constant Murley score, UCLA Shoulder Score, Simple Shoulder Test (SSD) score, and the Western Ontario Rotator Cuff (WRC) Index. These tools assess pain, function, and quality of life, helping guide ongoing management and ensuring that patients achieve the best possible results. Those seeking more information, several guidelines and resources are available. The American College of Radiology provides criteria for imaging chronic shoulder pain, while the National Institute for Health and Care Excellence (NICE) offers guidance on shockwave therapy. Canadian and European guidelines also exist for non-invasive management. Patient handouts and review articles can help individuals better understand their condition and treatment options. Staying informed empowers patients to participate actively in their care.